Welcome to part 4. We're going to talk about initial assessment of Afib, or getting the info you need to prepare your treatment plan when seeing a patient with Afib, or West Afib if you're using the cardiology mnemonics when they're coming up with clinical trials. We'll just go by initial assessment for today. Now it's time to start answering the question of how you're going to manage your patient who's in Afib. If you break it down to its most simplistic form, you're going to do one of two things. You're either going to control the heart rate, or you're going to control the rhythm. Now, this is an important distinction to make in regards to your goals for treatment. So for example, by choosing rate control, your goal is going to be to maintain a ventricular rate of less than 110 beats per minute. For the long-term management of Afib, rate control has become the preferred strategy. Now if you're using rate control, you need to keep in mind that the patient's rhythm is still going to be Afib. When you get an ECG, it's still going to be Afib. But as long as you keep that rate under control and you give them proper anticoagulation if it's indicated, then everything should be okay. But the important thing is maintaining that ventricular rate of less than 110. Now on the other hand, if you choose rhythm control, then your goal is going to be to restore and maintain normal sinus rhythm. But regardless of which option you choose, you're going to have the overarching goal of preventing a thromboembolic event in your patients. So let's talk a bit more about rate versus rhythm control and find out why rate control is currently the most prevalent treatment approach for the management of chronic Afib. In 2002, the New England Journal of Medicine published a trial comparing rate and rhythm control in patients with Afib, and this was known as the Affirmed trial. In this trial, there were 2,027 patients managed with rate control, and 2,033 were managed with rhythm control. The primary endpoint of the study was all-cause mortality at 5 years. The results of the trial indicated that among patients with non-valvular Afib, rate and rhythm control strategies had an equivalent impact on survival, although rhythm control did demonstrate a trend towards increased mortality. The rhythm control also had a higher incidence of hospitalizations, GI adverse events, and increased symptoms of Afib. So basically the takeaway from the Affirmed trial was that rhythm control offers no real advantage over controlling the ventricular rate in your typical elderly patient that's going to present with Afib. So generally speaking, if you're presented with a patient in Afib, you're likely going to take the rate control approach. There's no real difference in mortality. Overall, patients tolerate rate control better than rhythm control. And the other issue is that as patients get older, if you initially use rhythm control, there's a good chance that they may go back into Afib at some point, and that may go undiagnosed. If they're at home and don't seek follow-up, and they could go back into Afib for a prolonged period of time, and you would have no way of really knowing it unless they went and sought follow-up. And if they're in Afib for a long amount of time, that's going to increase their stroke risk. Rate control appears to be a better option overall for your patients, especially as they get older again. And of course, there are caveats to everything, and there are some instances where rhythm control is going to become necessary. So for example, if you have a younger patient with new onset Afib, cardioversion may be a good choice since younger patients are going to be less likely to revert to Afib than older patients will. Or if you have a patient who's unstable with hypotension and altered mental status, then cardioversion is likely going to be indicated because this is going to be an unstable patient. But of course, just like everything else in clinical medicine, it's not always black and white. So that unstable patient may not actually get cardioverted. But just very generally speaking, the unstable, hypotensive, altered patient with Afib may be a candidate for cardioversion. Or you may end up using rhythm control for patients where you can't control their ventricular rate, even though they're on adequate ventricular rate control therapy. But in general, for your normal Afib patient, your focus is likely going to be directed towards maintaining a ventricular rate of less than 110 and reducing the risk of stroke through the use of antithrombotic agents. So what are some basic pieces of information that you'll want to gather as you prepare to treat your patient? I'll try to take you through a general list that I try to go through in my mind as I'm looking up a new patient with Afib. I'm going to list a bunch of information, and then we'll revisit these questions as we work through a flow chart for managing your patients. So let's say that you're working in, say, an emergency department, since that's what I know, and a patient presents with Afib. So here's some information I typically try to gather. So first, what's the patient's age? Because obviously the older they are, the more difficult it'll be to cardiovert them if that's what's necessary. What's on their past medical history? Do they have a past medical history? Do they have a prior history of Afib? What about heart failure? Valvular disease? So in the case of valvular disease, you're going to be looking for things like valve replacement, stenting, any mention of mitral regurg, anything within a cardiology note that directs you towards valvular disorder will fall under this category. How about a history of stroke? Do they have hypertension? Is the case of Afib that they're presenting with an acute case? Is it recent onset? Is this AFib chronic? Has this patient had a known medical history of AFib? What's the duration of current symptoms? Has it been greater than 48 hours or less than 48 hours? Or does the patient even know when the symptoms came on, or do they even have symptoms currently? Because remember, not all patients are going to have symptoms of AFib. Some come in completely asymptomatic. A lot of the cases that we see are patients that present to clinic, whether it's their primary care clinic, cardiology clinic, any of our clinics. If they get an EKG and the patient's in AFib, say it's a fast AFib or an AFib with RVR, then more times than not they're going to send the patient down to our emergency department. That patient may come in completely asymptomatic, but it was just a clinical referral that we're seeing him. So remember, not all patients will have symptoms. Is the patient currently anticoagulated? If so, what are they receiving for anticoagulation? Are they receiving warfarin, apixaban, rivaroxaban, dabigatran? But regardless of which drug they're taking, you'll still want to check coag studies on them. So you want to check a PT-INR and an APTT. And you also want to look and see what the patient's current heart rate is. Is it faster than 110? Is it slower? What's the patient look like overall? Are they stable or are they unstable? Are they hypotensive? Do they have altered mental status? Or are they normotensive or hypertensive and they're just hanging out and doing okay? If the patient's unstable, is this chronic AFib with a fast rate? Or is this acute AFib with a fast rate? Or does the patient have a chronic history of AFib but has been non-compliant with therapy? If the patient's stable, on the other hand, have the patient's symptoms persisted for less than or more than 48 hours? And if it's been greater than 48 hours, how long have the symptoms been present? Does the patient tell you that he wants to be cardioverted today? Or if we're not going to cardiovert the patient, we'll need to calculate the CHADS-2 score. And I know this is kind of a long list, but everything will make sense in a few minutes. So for the remainder of the AFib lectures, I'm going to try to break everything down into a relatively simple flowchart, or at least as simple as I can make it, so you can use it to help guide your thought process when you're managing your patients. So we'll start with your general initial assessment, and then we'll move through the unstable arm, followed by the stable arm. And then after this, we'll talk about the drugs that you can use for initial and long-term rate control. Then we're going to talk about how to assess a patient's stroke risk, and we'll end with a discussion on the different antithrombotic agents that you can use. So now let's move on to part 5, and we'll cover the initial management of unstable and stable AFib.